Arthritis, MSK. Welcome to Radiology v the World. We will cover all about the radiology of arthritis. How to approach radiograph of hand. Let's start. The radiologic study of arthritis can be extremely difficult for the inexperienced because of the wide variety of patterns of disease, which produces a tremendous amount of overlap among the various diseases. What at first seems to be simple characterization of disease entities is found by the more experienced observer to be broad generalizations that may or may not fit into any one category of disease. These cases give an overview of radiologic evaluation of arthritis with the caveat that it is, by necessity, a simplified version and in no way complete. If one is interested in greater detail or more accuracy, the majority of arthritides are most easily examined and categorized by looking at their effect on the hands. Forrester recommends a search pattern that she calls the ABCs, with the A indicating alignment, B standing for bone mineralization, C standing for cartilage and including a search for erosions, and the S standing for soft tissues. I would add to this search pattern by making it the ABCDs, with the D indicating distribution of the pathology. Although this is implied in Forrester's search pattern, I believe it cannot be overemphasized. This busy slide is showing arthropathy distribution in the hands and wrists. Box 6.2 elaborating the hallmarks of degenerative joint disease. Box 6.1 Bilateral symmetrical arthropathy. Radiograph of the shoulder of the former professional baseball pitcher with long-standing shoulder pain, has joint space narrowing, subchondral sclerosis, and osteophytosis, which are hallmarks of degenerative joint disease, DJD. Please remember the three hallmarks of DJD are joint space narrowing, sclerosis, and osteophytosis. The only disorder that will cause osteophytes without sclerosis or joint space narrowing is diffuse idiopathic skeletal hyperostosis, DISH, as you will see in the next case note 2. Osteoarthritis is divided into two types, primary and secondary. A lateral film of the lumbar spine shows extensive osteophytosis without significant disc space narrowing or sclerosis. This is a classic picture for diffuse idiopathic skeletal hyperostosis, DISH. A radiograph of the left, A, and right, B, hands in a patient with primary osteoarthritis shows classic findings of osteophytosis, joint space narrowing, and sclerosis at the distal interphalangeal joints, the proximal interphalangeal joints, and the base of the thumb. This is bilaterally symmetric in this patient, which is typical for primary osteoarthritis. A type of primary osteoarthritis that can be very painful and debilitating is erosive osteoarthritis. It has the identical distribution as mentioned for primary osteoarthritis but is associated with severe osteoporosis of the hands as well as erosions. A young woman, who is a professional dancer, complained of left-sided hip pain. This AP of the pelvis demonstrated left SI joint sclerosis, joint irregularity, and erosions. A complete workup to rule out an HLA-B27 spondyloarthropathy was negative, and no laboratory or clinical evidence for infection was found. Her clinical history pointed to this process being completely occupation-related, and an aspiration biopsy to rule out infection was therefore not performed. This is not an unusual appearance for DJD joints which exhibit erosions of the SI joints. There are few exceptions to the classic triad of findings seen in DJD, sclerosis, narrowing, and osteophytes. Several joints also exhibit erosions as a manifestation of DJD. I call these joints the letter joints because they are all often called by their initials, the temporomandibular joint, TMJ, the acromioclavicular, AC, joint, and the SI joints. The symphysis pubis behaves similarly. Another process that can occasionally be seen in DJD is a subchondral cyst or geode.
Geodes are cystic formations that occur around joints in a variety of disorders. Box 6-4. The radiographic hallmarks are soft tissue swelling, osteoporosis, joint space narrowing, and marginal erosions. Box 6-5.
An erosive arthritis that primarily affects the carpal bones and the metacarpophalangeal joints is seen that has osteoporosis and soft tissue swelling. Note the soft tissue over the ulnar styloid processes. It is bilaterally symmetric process in this patient, which is classic. Rheumatoid arthritis has a large variety of appearances and can be difficult to diagnose with any degree of assurance from its radiographic appearance alone.
Note the severe joint space narrowing in this patient with rheumatoid arthritis. The femoral head has migrated in an axial direction with fairly concentric joint space narrowing. Minimal secondary degenerative changes have occurred, as noted by the sclerosis in the superior portion of the joint. However, these have been diminished somewhat by the osteoporosis that usually accompanies rheumatoid arthritis. In the hip, the femoral head tends to migrate axially, whereas in osteoarthritis it tends to migrate superolaterally. When rheumatoid arthritis is long-standing, it is not unusual for secondary DJD to superimpose itself on the findings one would expect with rheumatoid. Rheumatoid arthritis in the shoulder. An AP view of the shoulder in this patient with rheumatoid arthritis shows that the distance between the acromion and the humeral head is diminished, arrows. Ordinarily this space is about 1 finger breadth in width to allow the rotator cuff to move freely. This is a common finding in rheumatoid arthritis as well as in CPPD or with a torn rotator cuff. Please see below table as well. Secondary degenerative disease in the knee in a patient with rheumatoid arthritis. This patient has a history of long-standing rheumatoid arthritis. An AP view of the knee shows severe osteoporosis and joint space narrowing. Secondary DJD is occurring, as evidenced by the sclerosis and osteophytosis. However, these findings are out of proportion to the severe joint space narrowing. When DJD narrows a joint to this extent, the osteophytosis and sclerosis are invariably much more pronounced. The large paravertebral ossification on the left side of the T12L1 disc space, open arrow, is difficult to differentiate between an osteophyte and a syndesmophyte. Either could have this appearance. However, the paravertebral ossification at the left L1-L2 disc space, solid arrow, definitely has a vertical rather than a horizontal orientation, as does the faint ossification seen at the T11-D12 disc space, small arrow. These definitely represent syndesmophytes. Therefore, it makes sense to logically assume that the ossification at the T12L1 disc space is almost certainly a syndesmophyte as well. This patient has large non-marginal asymmetric syndesmophytes, which are typical of psoriatic arthritis or Reiter's syndrome. This patient indeed has psoriasis. A syndesmophyte is a paravertebral ossification that resembles an osteophyte except that it runs vertically, whereas an osteophyte has its orientation in a horizontal axis. Sometimes deciding whether a particular paravertebral ossification is an osteophyte or a syndesmophyte is difficult based on its orientation alone. Syndesmophytes are classified as to whether they are marginal and symmetric or non-marginal and asymmetric. A marginal syndesmophyte has its origin at the edge or margin of the vertebral body and extends to the margin of the adjacent vertebral body. Marginal syndesmophytes are invariably bilaterally symmetric as viewed on an anteroposterior AP spine film. Ankylosing spondylitis classically has marginal, symmetric syndesmophytes. Large, bulky, non-marginal asymmetric syndesmophytes, arrows, are seen in this patient with psoriatic arthritis. A syndesmophyte is a paravertebral ossification that resembles an osteophyte except that it runs vertically, whereas an osteophyte has its orientation in a horizontal axis. Marginal syndesmophytes are invariably bilaterally symmetric as viewed on an AP spine film. Ankylosing spondylitis classically has marginal, symmetric syndesmophytes. Inflammatory bowel disease has an identical appearance when the spine is involved. Non-marginal, asymmetric syndesmophytes are generally large and bulky. They emanate from the vertebral body away from the end plate or margin and are unilateral or asymmetric as viewed on an AP spine film. Psoriatic arthritis and Reiter's syndrome classically have this type of syndesmophyte. Bilateral, symmetric SI joint sclerosis and erosions are seen in this patient with ankylosing spondylitis. Inflammatory bowel disease could have an identical appearance. Although this is classic for these two disorders, It would not be that unusual for this appearance to be seen with psoriatic disease or Reiter's syndrome. It would be unlikely for infection or DJD to be bilateral in this fashion. This case is showing psoriasis with SI joint disease. Unilateral SI sclerosis and erosions are seen in this patient with psoriasis. Ankylosing spondylitis and inflammatory bowel disease virtually never have this unilateral distribution. CT scan of the SI joints in psoriasis. A CT scan through the SI joints in this patient with psoriasis shows unilateral SI joint sclerosis and erosions, arrows, typical for psoriasis or Reiter's syndrome. Figure A cartilage loss at the proximal interphalangeal joints of the third, fourth, and fifth digits in this hand is apparent, with erosions noted most prominently in the fourth and fifth digits. These erosions are not sharply demarcated but are covered with fluffy new bone, which are termed proliferative erosions. Note also the periostitis along the shafts of each of the proximal phalanges. Figure B advanced psoriatic arthritis. Fusion or ankylosis is apparent across the proximal interphalangeal joints of the second through the fifth digits. Several of the distal interphalangeal joints are also ankylosed. Severe joint space narrowing at the metacarpophalangeal joints is noted. This distal arthritis is typical for psoriatic arthritis. Psoriasis causes a distinctive arthropathy in the hands that is characterized by its distal predominance, proliferative erosions, soft tissue swelling, and periostitis. The erosions are different from the clean-cut, sharply marginated erosions seen in all other erosive arthritides in that they often have fuzzy margins with wisps of periostitis emanating from them. A lateral view of the calcaneus in a patient with Reiter's syndrome shows poorly defined new bone on the inferior margin of the calcaneus with a calcaneal spur that is also poorly defined. This is typical of psoriatic arthritis or Reiter's syndrome as opposed to the well-formed calcaneal spur in DJD. An AP view of the great toe in a patient with Reiter's syndrome shows fluffy periostitis in the erosions adjacent to the interphalangeal joint of the great toe. Marked soft tissue swelling is also present throughout the great toe. These changes are typical in appearance and location for Reiter's syndrome or psoriasis. Hand radiograph. Marked diffuse and focal soft tissue swelling is present throughout the hand and wrist in this patient with long-standing gout. Destructive, large, well-marginated erosions, some with overhanging edges, are noted near multiple joints. The focal areas of soft tissue swelling are called tophi, some of which are calcified. These calcify only with coexistent renal disease. The arthropathy caused by gout is very characteristic radiographically, yet it is not commonly seen. Why is that? Because it takes 4 to 6 years for gout to cause radiographically evident disease, and most patients are successfully treated long before the destructive arthropathy occurs. The classic radiographic findings are well-defined erosions, often with sclerotic borders or overhanging edges. Soft tissue nodules that calcify in the presence of renal failure. And random distribution in the hands without marked osteoporosis. I know of no other disorder that typically has erosions with sclerotic margins. Therefore, this is a very specific finding for gout. It typically affects the metatarsophalangeal joint of the great toe, called podigram. A sharply marginated erosion with an overhanging edge, arrow, is seen in the metacarpophalangeal joint in the great toe in this patient with gout. This appearance and location are classic for gout, whereas psoriasis and Reiter's syndrome usually involve the interphalangeal joint and do not have erosions that are this sharply marginated. Chondrocalcinosis in the wrist. This patient with CPPD exhibits chondrocalcinosis in the triangular fibrocartilage of the wrist, curved arrow. Triangular fibrocartilage calcification is one of the more common locations for chondrocalcinosis to occur. Calcium pyrophosphate crystal deposition disease, CPPD, causes much confusion among radiologists as well as other specialists. CPPD has a classic triad, pain, cartilage calcification, and DJD. Chondrocalcinosis in the knee. Cartilage calcification, known as chondrocalcinosis, is seen in the fibrocartilage, arrows, and in the hyaline articular cartilage in this patient with CPPD. CPPD arthropathy. Degenerative joint disease of the elbow is seen in this patient with CPPD. Note the joint space narrowing with minimal sclerosis and the large osteophytes, arrows. Osteophytes of this nature are termed drooping osteophytes and are often seen in CPPD. The elbow is an unusual place for DJD to occur except in the setting of CPPD or trauma. CPPD arthropathy. Marked DJD at the radiocarpal joint is seen in this patient with CPPD. Severe joint space narrowing and sclerosis with large subchondral cysts or geodes are hallmarks of DJD. This is an unusual location for DJD except in the setting of CPPD. This patient with CPPD shows severe joint destruction in the carpus primarily at the radiocarpal joint. A. Large subchondral cysts or geodes are noted. Heterotopic new bone or joint debris is also seen, arrow. B. Dislocation of the radiocarpal joint is seen, with the entire carpus lying volarly in relation to the radius. The findings of severe joint destruction, heterotopic new bone, and dislocation are classic for a Charcot's joint. This patient, however, had sensation in this joint. Therefore it is not a true Charcot's or neuropathic joint but a pseudo-Charcot's joint, which is occasionally seen in patients with CPPD. 3 diseases have a high degree of association with CPPD: primary hyperparathyroidism, gout, and hemochromatosis. This is not a differential diagnosis for chondrocalcinosis. These diseases tend to occur at the same time that CPPD occurs. If the patient has one of these 3 disorders, he or she is more likely to have CPPD than is a healthy person. This is case of systemic lupus erythematosus. Marked soft tissue wasting, as noted by the concavity in the hypothenar eminence, and ulnar deviation of the phalanges, as is seen primarily in the right hand in this patient, are hallmarks of SLE. The striking abnormalities in the hands in each of these disorders are osteoporosis and soft tissue wasting. SLE characteristically has severe ulnar deviation of the phalanges, as shown in above case. Erosions are generally not present in these diseases. This case of the scleroderma, diffuse subcutaneous soft tissue calcification is seen throughout the hands and wrist in this patient with scleroderma. Soft tissue wasting and osteoporosis are also present as well as bone loss in multiple distal phalanges. Acroosteolysis, secondary to the vascular abnormalities, are often present in this disease. Soft tissue calcifications are typically present in scleroderma and dermatomyositis. This is another case of the scleroderma. An AP view of the hand in this patient with sarcoid demonstrates classic changes of bony involvement with this granulomatous process. Note the lace-like pattern of destruction seen most prominently in the proximal phalanges and the distal third phalanx. Soft tissue swelling and some areas of severe bony dissolution are also noted, which occur in more advanced patterns of sarcoid. These changes are typically limited to the hands but can really occur in other parts of the skeleton. Frontal radiograph of the fingers, lace-like pattern of lucency and coarse trabeculae within the phalanges of the 3rd and 4th digits. Soft tissue swelling of the 3rd and 4th digits and punched out lytic lesion of the 5th DIP joint, white arrows, preservation of joint spaces, black arrowheads, with no evidence of periostitis. Non-caseating granulomatous lesions are characteristic of sarcoidosis and underlie the lace-like bone appearance caused by the development of cystic areas with sclerotic rim scalloping and ossific deformity, with trabecular coarsening and eventual destruction of bone. CPPD, calcium pyrophosphate dehydrate, deposition leads to distinctive gout-like pattern of arthritis, pseudogout, structural joint damage, pyrophosphate arthropathy, calcification of articular cartilage, knee, hip, shoulder, TFCC, symphysis, patellofemoral compartment involvement. Pseudogout arthropathy, similar to OA, medial joint space narrowing, subchondral sclerosis, osteophyte formation. AP and oblique hand radiographs show fusiform soft tissue swelling of the third finger and, to a lesser degree, the second and first digits. There is an early marginal erosion with adjacent mild bone proliferation giving rise to a subtle mouse ear deformity at the second pip joint, white arrowhead. More severe erosive disease and tuftal resorption give a pencil in cup appearance to the first IP joint. Third pip in DIP joint subluxation is noted at multiple MCP joints. There is no evidence of osteoporosis. Diagnosis is psoriatic arthritis. Marginal erosions characterize this disease, with erosions of joints originating peripherally at bare areas and proceeding centrally to form early mouse ear and late severe pencil in cup deformities. AP view of the hand reveals marginal erosions and soft tissue swelling involving the DIP joints of the index and long fingers, shown to better advantage in the cone-down view, Fig. 2. Note also the associated areas of ill-defined, fuzzy bone proliferation, arrows. Final diagnosis is psoriatic arthritis. While the appearance may resemble rheumatoid arthritis, helpful differentiating features seen with psoriasis include asymmetric involvement of the distal, pip and DIP joints, array-like distribution of bone changes and soft tissue swelling, sausage digit, and especially the presence of ill-defined bone proliferation at the sites of involvement, as illustrated in this case. AP radiograph of the thoracic spine demonstrates multi-level ankylosis with a subtle cleft-like lucency at the T89 level. Lateral view reveals the distracted fracture at that level to better advantage, large arrow. Additionally, thin marginal syndesmophytes, characteristic of ankylosing spondylitis, are better demonstrated at other levels, small arrows. Spinal fractures can occur in patients with ankylosing spondylitis with even mild trauma owing to the rigidity of the fused spinal column. Fractures may extend through the ankylosed disc, as in this case, as well as through any part of the vertebral elements, and commonly involve all three columns of the spine. Lateral radiograph of the cervical spine demonstrates complete ankylosis of the spine, as well as solid bone effusion of the facet joints, arrowheads. Ankylosing spondylitis often results in extensive ankylosis of the disc spaces, facet joints, and posterior elements, resulting in a bamboo spine appearance. The thin, marginal syndesmophytes present in this case are typical of patients with ankylosing spondylitis and inflammatory bowel disease, as opposed to the large, bulky, non-marginal syndesmophytes seen with psoriatic arthritis and reactive arthritis. AP view of the pelvis demonstrates irregularity and prominent marginal sclerosis along both sacroiliac joints compatible with sacroiliitis. AP view of the lumbar spine reveals bulky, asymmetric non-marginal syndesmophytes. Note how the syndesmophytes arise from the mid-vertebral bodies, unlike the marginal syndesmophytes of ankylosing spondylitis. PA view of both hands reveals extensive bilateral erosive changes involving the fingers with accompanying areas of nodular soft tissue prominence. Figure 2 cone-down views demonstrate large para-articular erosions, large arrow, overhanging edges along some of the erosions, arrowheads, and high density within the areas of soft tissue prominence, small arrows. Classic radiographic findings include large erosions, may be marginal, para-articular, or intraosseous, often with characteristic overhanging edges. Prominent nodular foci of localized soft tissue swelling that may demonstrate increased radiodensity related to urate crystals. And preservation of the articular cartilage until very late in the disease. Periarticular bone density is also usually preserved. Figures 1 and 2, AP and oblique radiographs, large erosions with sclerotic borders and an overhanging edge of cortex most evident at the base of the first proximal phalanx are present at the medial and lateral sides of the FRCR joint, white arrows, with prominent medial soft tissue swelling and associated hallux valgus deformity. Erosion also noted at the second TMT articulation, black arrows. The first MTP joint spaces, relatively preserved. Other erosions are present near the TMT joints. Mineralization is normal and no soft tissue mineralization is present. Radiographic manifestations include 1. Punched out erosions with sclerotic borders, mouse bite appearance, 2. Overhanging edge of cortex, 3. Joint space preservation, 4. Asymmetric polyarticular distribution, 5. Normal mineralization, 6. TOFI, soft tissue masses that may or may not calcify, in long-standing disease. Findings, AP radiograph figure 1, reveals narrowing of the medial joint compartment with some central spurring along the tibial spines. There are faint calcifications within the medial meniscus and articular cartilage, arrows. Figure 2, lateral radiograph shows severe narrowing of the patellofemoral joint compartment as well as curvilinear calcifications in the suprapatellar tissues, arrow. Diagnosis is calcium pyrophosphate deposition disease, CPPD. An AP view of the hand in this patient with hemochromatosis shows severe joint space narrowing throughout the hand, which is most marked at the metacarpophalangeal joints. Associated sclerosis at the metacarpophalangeal joints with large osteophytes seen off the metacarpal head suggests DJD. These are unusual joints for DJD to occur in, yet this is the classic appearance of hemochromatosis. No chondrocalcinosis is seen in the triangular cartilage in this patient. However, a small amount of chondrocalcinosis can be seen at the second metacarpophalangeal joint, arrow. 50% of patients with hemochromatosis also have CPPD. An AP view of the knee in this patient with tabes dorsalis shows the classic changes of a neuropathic or Charcot's joint. Note the severe joint destruction, the subluxation, and the heterotopic new bone, arrow. Please remember 60 Charcot joint. Density change, subchondral osteopenia or sclerosis, destruction, osseous fragmentation and resorption, debris, intra-articular loose bodies, distension, joint effusion, disorganization and dislocation, joint malalignment due to ligamentous laxity. An AP view of the spine in this paraplegic patient shows severe destruction of the L2 and L3 vertebral bodies and the intervening disc space, heterotopic new bone, arrow, and malalignment or dislocation. Dislocation of the second and third metatarsals along with joint destruction and large amounts of heterotopic new bone are present in the foot of this diabetic patient. These findings are classic for a Charcot's joint that has been termed the Lisfranc's fracture dislocation. It is most commonly seen secondary to trauma rather than as a Charcot's joint but is the most common neuropathic joint seen today. A lateral view of the knee in this patient with juvenile rheumatoid arthritis shows the classic findings of overgrowth of the ends of the bones and associated gracile diaphyses. These changes can also be seen in hemophilia or paralysis patients. An AP view of the ankle in this patient with hemophilia shows subtle changes of overgrowth of the distal tibia and fibula as compared with the diameter of the diaphyses. Some joint destruction of the tibiotalar joint is also noted. Hemophilia. An AP view of the elbow in this patient with hemophilia shows overgrowth of the ends of the bones, in particular the head of the radius, and marked joint destruction. JRA could certainly cause an appearance such as this. Synovial osteochondromatosis. An AP view of the hip in this patient with left hip pain shows multiple calcified loose bodies in the hip joint. The loose bodies are all of a similar size. Therefore, this is diagnostic of primary synovial osteochondromatosis. Synovial osteochondromatosis. Multiple calcified loose bodies are seen in the suprapatellar space of the knee in this patient. The loose bodies are of different sizes. Therefore, this is diagnostic of secondary synovial osteochondromatosis. Figure 1 shows that multiple intra-articular osteochondral bodies are present within the left shoulder joint involving the subscapular recess, subcoracoid recess, and axillary pouch. Figure 2, axial PDMRA confirms multiple high signal intensity, similar to intramedullary fat, rounded bodies with peripheral rings of thin low signal intensity, as shown by white arrows, within the subscapular recess. Figure 3 facts at T1 post-gadolinium MR image demonstrates fat saturation of multiple bodies, white arrows, within joint fluid/synovial thickening. No fracture or marked joint space narrowing is noted. Diagnosis is synovial osteochondromatosis, primary. Synovial osteochondromatosis without calcification. An AP view of the hip in this patient shows the femoral neck to be virtually whittled down, with the femoral head undercut, giving an apocore appearance. This has occurred from the pressure erosion of multiple non-ossified loose bodies in the joint. This is non-ossified synovial osteochondromatosis, which is probably more properly termed synovial chondromatosis. It usually does not cause this degree of bony erosion and is indistinguishable from pigmented villonodular synovitis. Pigmented villonodular synovitis. An AP view of the hip in this patient shows joint space destruction and bony erosions throughout the femoral head and neck. PVNS or synovial chondromatosis, non-ossified, could have this appearance. Pigmented villonodular synovitis. Sagittal T1 weighted, A, and FSCT 2 weighted, B. Images of an ankle with PVNS show a soft tissue mass emanating from the ankle joint, which is low signal on both sequences and has very low signal humors that are in lining parts of the synovium. This is characteristic for PVNS. Early avascular necrosis of the hip. Patchy sclerosis is present throughout the femoral head in this patient with a renal transplant and AVN of the right hip. No subchondrolucency or articular surface irregularity in the weight-bearing region is yet present, with the exception of a small cortical irregularity seen laterally. Avascular necrosis of the hip. A definite subchondrolucency, arrows, is seen in the weight-bearing portion of this hip with AVN. Patchy sclerosis throughout the femoral head is also noted. Avascular necrosis of the shoulder. Articular surface collapse is present in the shoulder with long-standing AVN. Dense bony sclerosis is also present. Osteochondral lesion. A small focal area of AVN in the medial condyle of the femur, black arrows, is present, which is an OCL. Part of the area of AVN has shed a bony fragment, White's arrow, that is loose in the joint and known as a joint mouse. Kienbock's malacia. AVN of the lunate, or Kienbock's malacia, is demonstrated in this patient. Note the increased density and partial fragmentation of the lunate. Freiberg's infraction. Flattening, collapse, and sclerosis of the second metatarsal head, as seen in this patient, is typical of AVN or Freiberg's infraction. It can also involve the third or fourth metatarsal heads. Note the compensatory hypertrophy of the cortex of the second metatarsal, which is invariably found with this disorder. Colorist disease. Flattening and sclerosis of the tarsal navicular, arrow, in children is thought by many to be AVN and is called Color's disease. Others have found this to be an asymptomatic normal variant and believe that it is an incidental finding. Haglund syndrome. Extensive erosive changes in the posterior-superior aspect of the calcaneus are associated with new bone formation and localized soft tissue mass secondary to retrocalcaneal bursitis. Inflammatory calcaneal spur, intensified. A broad-based plantar calcaneal spur is associated with fluffy periostitis about the posterior and inferior aspect of the calcaneus, Reiter's syndrome. Circumferential loss of joint space. Concentric, axial, narrowing of the joint space is associated with tiny articular erosions, extensive fluffy enthesopathy along the ischium and greater trochanter-infused sacroiliac joints. Mild protrusio acetabular is also present, ankylosing spondylitis. Asymmetric loss of joint space. Narrowing of the joint space is limited to the superior, weight-bearing area of the hip and is associated with reactive sclerosis and subchondral cyst formation, osteoarthritis. Thanks, hope no more worry about arthritis. If you like our video, please like it, share it and subscribe our channel. Click on bell icon so that get notification for next video.